down like a yo-yo. Right, when and how to intervene, I wish I knew, but I'll give you some clues. So, never say never, but at least in the UK, surgery is not required for nutritional rickets. So most of this talk is going to be centred around the X-linked hypophosphatemic rickets, where we know where the specific abnormality is, and a little bit about the renal osteodystrophy bone problems that we see. So orthopaedically, rickets comes to us because of delayed linear growth and relative short stature, and there will be deformity. They have symptoms like aching legs and fatigue, and with a family history, the child may present to you much more promptly. Historically, surgery for rickets, hypophosphatemic rickets, was fraught with problems with high recurrence rates, high complication rates, and it was generally felt to be better to delay surgery until close to skeletal maturity. But maybe that was when the deformities had been allowed to get worse over time, and it didn't seem quite right to me. Currently, medical management is much better than it was, and guided growth techniques have become increasingly popular. We've also thought about the chondral modelling theory of Frost, which says that if you've got physiological loading, be it tension or compression, it will stimulate growth via a negative feedback loop. So if you drift into valgus, the loop will bring you back to neutral. If you drift into varus, it will bring you back, if you believe in this chondral modelling theory. And that assumes that the physis is normal. Or maybe it's a physis that is abnormal but is under good treatment, in which case maybe it will behave as normal. So I feel that there is a window of opportunity to guide the growth of the young rachitic skeleton. And you can guide the growth at the physeal level where maybe the primary problem lies, and you may be able to help prevent this secondary diaphyseal deformity. If I help the bones grow straight, medically and surgically, will they stay straight? And would there be less problems later if I intervened aggressively early? So at Great Ormond Street Hospital, our philosophy since 2005 has been to treat skeletal deformity early, but only if it persists despite 12 months of maximised medical management. And we've been primarily concerned with deformity in the sagittal plane, because that's, of course, the easiest one to treat. When talking about indications for surgery, of course, it's the classic, the history, the examination and the investigations, a full history, a complete examination, and investigations appropriate to the questions that you want to answer. Our children often have pains and muscle aches and pains, they fatigue easily, poor exercise tolerance, and a bit of a Trendelenburg-type waddle. They've got multiplanar deformity, and they may have periarticular swelling, amongst other things. And the investigations that I'm most interested in are whether the rickets is healed biochemically and or radiographically. It's important to work as part of a multidisciplinary team. I've taught the renal physicians that this is a metabolic bone disease, and therefore there is some value in doing some X-rays routinely. I've learnt from them the importance of the compliance with medical treatment if my surgery is to work. Some of the key features we're looking for are, of course, clinically, the foot progression angle, because that's often a cause of parental concern. We know that when we're assessing a torsional profile, if we have the feet facing forward, the legs can look bowed. If we have the kneecaps facing forward, the bow disappears, but the torsional abnormality is seen. And of course, we should be doing the torsional profile perhaps in the prone position. Radiographically, again, one of the key features I look for is a standing long leg radiograph. It should be well centered with the patellae facing forward, and you can use that to assess the deformity, the leg length, and the state of the rickets. Does it look as if it's healing or healed? My indications for surgery are persisting deformity after maximised medical treatment. These are just my indications. They're defined by a mechanical access outside the knee, so that's in zone 3 or zone 4, or a documented mechanical access that is progressing through zone 2 despite maximised medical treatment. Of course, you've got to do more than just take a standing X-ray, because the deformity is often in more than one plane. It's often at more than one site, and certainly in the older child there may be significant diaphyseal deformity. And I'm deciding whether my surgical treatment is aimed at perfection in one attempt, or maybe just to get it as good as I can get it at this early stage. Guided growth technique, we've tended to use plates at all sites of deformity, i.e. proximal tibia and or distal femur. The aim of treatment is to get mechanical axis 0, zone 0, completely in the middle, and then we take the plates out. We have not so far aimed for overcorrection. And we've also made a point of assessing the diaphyseal deformity correction as we go. So our results, and these are updated from the paper we published last year, 62% of our cohort did require guided growth surgery, so despite maximal medical treatment. We've had 30 limbs that have completed treatment, meaning full correction or skeletal maturity, 18 varus, 12 valgus, 38 limb segments, 70% have achieved neutral alignment and 20% have improved. Our mean correction time was 16 months. The younger the patient, the quicker it happened. The distal femur corrected quicker than the proximal tibia. The diaphyseal correction was quite impressive in the younger children. We've had no real recurrence, no major complications. We have had some failure to correct, and additional operations have been required. What have we learnt? Legs that grow straight, on the whole, stay straight if metabolic control is maintained. Diaphyseal deformity is less of a problem if you correct the coronal deformity early, and torsional problems tend to improve too. We've also learnt that straight legs can develop varus in adolescence, and these do not do well with guided growth. But if we don't like the guided growth approach, and a lot of people don't, the alternative approach is that, as published again in the same year by Philip Rickets' team. And their conclusion, again, is medical treatment is the first line of treatment. Surgery before puberty is associated with a high risk of recurrence, and such procedures should only be recommended following an MDT discussion in patients with severe distortion leading to mechanical joint and ligament complications. So they're very much in favour of doing surgery later. My comments on this are it's 49 cases, but over a 40-year period from 4 centres. And these patients had very variable medical and surgical management. And whilst I take the paper, its important messages, I think it's a little bit more of a historical review of surgical management than a current one, but that's just my opinion. If I don't like guided growth, what can I do? Well, I can do an osteotomy, and in simple terms, I just want to define the deformity, correct the deformity. So I want to break the bone, bend it straight, and then hold it straight. So what do I do and when? Depends on the age. So we used to, before guided growth, do quite a lot of early proximal tibial osteotomies, pins and plasters, or a rush pin, stabilise the osteotomy, get the child going quite quickly. Or we can break the bone, bend it straight, and hold it, but with a plate and screws. And again, get the patient going as quickly as we can. If we don't like that way, we can do it with an intramedullary nail, and again, get the patient going quickly. So there are many, many ways of dealing with the patient who's close to skeletal maturity. And of course, once you've done one side, you have to look again at the other side and decide whether that side needs doing too. And then you've got to keep an eye on the leg lengths and try and make sure that they're equal at the end of your surgical interventions. And if we don't like any of those techniques, and this is a straight leg that became varus in adolescence, guided growth may have optimistically stopped it getting any worse, but it didn't correct it. So we had to break the bone, bend it straight, and this time we held it with an external fixator and got the patient going again quite quickly and improved their mechanical alignment. And again, we may well need to address the other side now. There are other issues. I've so far concentrated on the knee, but the proximal femoral alignment is also important. And this might be an accident waiting to happen, not in terms of the epiphysis slipping off the metaphysis, but maybe by having development of a pseudo-fracture. And certainly pseudo-fractures are not uncommon, even in the well-treated patient. This is a 15-year-old girl playing hockey regularly, but did have a little more discomfort after games than her peer group did. We need to assess her deformity, advise her to restrict her activities whilst we plan surgical intervention. And of course, patients with renal disease may have hip and knee pain with lymph and irritability, and you may find that they're slipping their epiphyses. And in these young kids with metabolic bone problems, I've tended to use a growing screw system as a way of stabilizing the deformity whilst the physis continues to grow and correction of the deformity can occur. If you get the real AVN changes in renal osteodystrophy, secondary perhaps to steroid use, these are patients who've often had a renal transplant, immunosuppression, you have to consider doing quite a marked proximal femoral reconstruction. So in summary, it's a changing world, and it remains a challenging condition to treat. There are some unanswered questions: what to do, when, and how to assess success. There are very few quality of life measures to try and judge the success of medical and or surgical treatment. But I do believe there is a role for guided growth in the young patient, pending a sort of fine-tuning osteotomy in your older patient. Thank you.